Welcome to Infectious Conversations, the Infectious Diseases podcast recorded at WVU Medicine in Morgantown, West Virginia. And now your host, Dr. Meera Mehta.
Hello, everyone, and welcome to another episode of Infectious Conversations. This is WVU Medicine's Infectious Diseases podcast, and this is actually our first episode for 2024, so we're really excited about that. My name is Dr. Meera Mehta. I'm a clinical infectious diseases pharmacist at Ruby Memorial Hospital, and today we have a great guest with us, Dr. Megan Hardy. Megan, thank you for coming on the show.
Thanks so much for having me. Like Meera said, my name is Megan Hardy. I am a clinical pharmacy specialist in infectious diseases at WVU Medicine, and I joined the team at Ruby in August of 2023, so still fairly new, but really happy to be here.
Yeah, we're really excited that you're here. Megan is also a black belt in both karate and jiu-jitsu, so I absolutely had to mention that. So today we're going to be talking about an emerging fungal infection caused by an organism called Candida auris. Now, if you've been keeping up with headlines recently, you may have noticed that in January, there was an outbreak of Candida auris that occurred in Seattle, Washington. It happened in 4 patients who were residing in long-term acute care facilities. Now, the number of Candida auris infections is on the rise. So in 2019, there were approximately less than 500 cases, and that grew to about 2,400 cases in December of 22. So this is an infectious disease that is rapidly spreading. And Megan, can you tell us what exactly is Candida auris and what makes it unique from the other type of fungal infections that we're used to seeing?
Absolutely. So Candida auris is a type of yeast. So we're most commonly familiar with other Candida species that are other types of yeasts, and we see those causing infections more frequently. However, Candida auris is a little bit different because it can cause this really severe infection in a lot of, in certain specific populations, which other Candida species can. But what makes Candida auris specifically unique is that it's often resistant to a lot of the antifungal therapies that we use to treat some of the other Candida species and yeasts. So that makes it a little bit more difficult to treat when a patient is clinically infected. And it also spreads very easily among patients, especially within hospital facilities or any sort of acute care facilities, anywhere where patients are in close contact with one another. And even though a patient can be colonized with Candida auris, which also makes it unique, so a patient can be colonized without having a true infection, and even if they're not clinically infected, they can still very easily spread that disease or spread the Candida auris to another patient in close contact. So it makes it extra hard to take control of it when there is an outbreak and mitigate the spread. And
Megan, Candida can live on surfaces as well. Is that correct?
Yes, absolutely. So this particular species of Candida auris can live on surfaces for a couple of weeks.
Wow.
So, and it can be transmitted by touching those surfaces. So that's something that also we need to really stay on top of when we do have any sort of exposure to Candida auris, especially in a healthcare setting.
Right. And it seems that it could also be spread by devices or potentially objects that are used in the healthcare setting as well. Megan, what are the biggest risks for Candida auris? I know you mentioned it probably doesn't affect immunocompetent people, but who particularly would be at risk for getting this type of infection?
Absolutely. So we talked a little bit about where the patients were residing as far as the outbreak that occurred in Seattle, Washington, and where other outbreaks throughout the United States occur. So aside from patient factors themselves, due to the nature of the Candida auris, it can spread easily in any sort of long-term care facilities or nursing homes. Long-term acute care facilities are really where we see it spreading the most. And that just is about, kind of the spread itself, not necessarily the clinical infection. So patients at highest risk of clinical infection, like you said, are not immunocompetent patients. It's not as much of a threat to healthy patients as it is for immunocompromised patients or anybody who has had recent surgeries or was just on a prolonged course of antibiotics. So primarily patients with any sort of weakened or immunocompromised system are at highest risk of actually contracting it and having it being an infectious organism to them. It's really quiet.
All right, thank you for that information. So now that we know what the risk factors are, how do we handle this organism? So how is Candida auris typically treated?
Sure. So because it spreads so easily, the best thing that we can do if we do have a patient that does have Candida auris or has any history of Candida auris is prevent it from spreading. So even before we get to the whole treatment aspect of it, it's really important to manage manage that patient from a contact isolation perspective. So we want to get infection control on board as soon as we possibly can. Isolate that patient, get them to another room. Everything needs to be disinfected with special, really heavy-duty disinfectants by people in gowns and gloves. And typically, anybody who has been exposed to that patient or anybody even on that patient floor, it's recommended that they get screened for Candida auris as well. So they can do screening via there's like topical like skin screening tests. You can also do like urine, blood, sputum to test for Candida auris as well. So if any of that comes back positive, even if the patient is just colonized with it and not actually exhibiting any signs or symptoms of infection, they need to be put in isolation because once again can live on surfaces for so long. So typically what they'll do is test everybody on the floor and put everybody under contact isolation, really to prevent the spread to other patients and also to other parts of the hospital. So the CDC actually recommends against treating patients who are just colonized with Candida auris.
Okay.
So if they do have, so a lot of times these screening tests will come back positive and it can just reside on the skin for a really long time, or sometimes we see it in sputum cultures and the patient isn't having any signs or symptoms of infection. The CDC recommends against treating those patients with any sort of antifungal medications because there's no data to suggest that that will prevent them from becoming clinically infected. So the only time that we treat patients is when they actually are exhibiting any sort of infectious symptoms. And like we mentioned earlier, Candida auris is resistant to like fluconazole in a lot of our azole antifungals that we're typically using to treat a lot of other Candida species. So
yeah, I actually read that fluconazole essentially isn't helpful at all with Candida auris. And then amphotericin, which is one of our broadest spectrum IV antifungal agents, I read that 50% of isolates can be resistant to that. And then our echinocandins, our IV echinocandins, about 5 to 10% of these Candida auris species can be resistant to those IV antimicrobials as well. So treatment seems to be quite challenging.
Yes, definitely.
Are there any potential treatment options for this?
Yeah, so typically, if you have a patient coming in with a Candida auris and we don't have sensitivities on it, we have no idea what it's going to be even sensitive to. Like you had mentioned, it has really unreliable sensitivities to like amphotericin B and echinocandins as well. Typically, we'll try to empirically treat with an echinocandin first, and if there isn't any clinical improvement, usually they'll give it about 5 days or so, and then they recommend trying Ampho B. And so if you don't have any improvement on either of those, we do have some novel agents developed for really resistant Candida species like this. So ibrexafungerp is one of them. I haven't personally seen it used in practice yet, however, like in my limited experience with it. But there are some novel antifungal agents that have some that are, we're hopeful are going to be able to target something like Candida auris.
Sure, absolutely. Megan, have you had any experience with this organism as well?
I do have a little bit of experience during my second year of residency up in Detroit with just small outbreaks within the hospital, mostly from clusters of patients who have come from nursing facilities or nursing homes. I haven't had any clinically infected patients that I have helped advise on antifungals or anything like that. Luckily, it's been kept to mainly colonization. And so, like I had talked about, those patients were, and the patients on the entire floor were screened for Candida auris, and the whole unit was put under contact precautions until everything was cleaned and everything was clear, or those patients were discharged. So a couple of little outbreaks, a handful of patients just over the course of a couple of years, but nothing that required a lot of any sort of novel antifungals or anything that we had to use, but mostly just from a contact precaution and an infection control standpoint.
Okay, that's really interesting. It's great to have someone on our team who actually has seen this organism before, so that we have someone experienced with that. Another note I wanted to say is the CDC does track cases. So if you do go on the CDC website, they are tracking by state the number of cases that caused active infections, as well as the number of cases where patients were colonized as well. And it is recommended that if there is a case of Candida auris, that this gets reported to local health departments as well. Megan, as we close the podcast, do you have any final comments at all about Candida auris in general?
No, just mostly just being aware that it exists, that it just is something kind of to be on the radar. Hopefully we don't run into it a lot in our healthcare facilities, but if we do, then we do have some great CDC guidance to point us in the right direction on where to go next. So.
Yeah, that's great information. So it's not really something that's running rampant, especially in our area right now, but it is something for us to keep an eye on. Well, thank you so much for tuning in today's episode of Infectious Conversations. I was your host, Dr. Mira Mehta, and Megan Hardy was our guest today. Hopefully you'll join us for our next episode next month. It's going to be on foodborne illnesses, and we have a great guest speaker, Carissa Tedeschi. So we'll hope that we will see you then.